take this information. I've been trying to narrow it down. I gotta get it done before tomorrow morning, so I got 8 o'clock class and 1 to 4 tomorrow with them. So hopefully I'm gonna be up most of the night probably. All right. Well, so from all the information you have so far, you made a tentative diagnosis of hypercortisolism, because it sounds like it doesn't too much of the stuff. Well, you measure resting blood cortisol levels and do an ACTH response. And what about our resting blood cortisol levels? Very low. Does that go along with all this clinical signs of hypercortisolism? So what does it tell you is causing those clinical signs? Is it what the body's producing or what it's been getting? It's what it's been getting. And what has happened, why is because remember those steroids don't interfere with the cortisol. We're using dexamethasone and stuff for the treatment, doesn't interfere with this. So why are we getting such low resting cortisol levels? What has happened to the adrenal gland while they were getting all of these steroids? Atrophy. So what have we have clinical signs of hypercortisolism, but we start backing off of the steroids, and what are we going to end up with? Hypoadrenalcorticism, because that's what's actually the underlying problem in the animal, isn't it? Okay. Post-ACTH. What do you think? What's going on? Walking went from 0.4 to 0.5, right?
Progress.
So does that confirm that we have a adrenal problem going on here? Right. So basically that tells us there's an adequate response to ACTH stim, but it's due to hypo, not hyper. The hyperadrenalcorticism is iatrogenic. It's caused by what the animal's getting. But that has been going on long enough that it has caused, what does it cause the adrenal to do? To shut down. And so now, this is the result. So what are we trying to do? We want to try to take them off these exogenous steroids, don't we? But does this tell us we can just do it right away, or are we going to have to be very careful about it? Very careful. Okay. So what's your diagnosis? It's going to be iatrogenic hyperadrenalcorticism due to long administration of corticosteroids in the dog right now. And what condition has been produced? Produced, we've gotten hypoadrenalcorticism produced. Okay. So based upon history, physical, clinical, and laboratory findings, which is the pathophysiological mechanisms of endocrine disease is responsible for this dog's condition? What did we just say? Iatrogenic syndrome of hormone excess. What change probably has occurred in the dog's adrenal glands? Atrophy. Everybody clear on that? On an endocrine gland functional status, what is the classification of this dog's hypoadrenalcorticism?
Secondary.
Primary, right?
It's in the pituitary.
Secondary.
It's going to be secondary because what has the steroids inhibited the dog from being released? ACTH. So what type of hypoadrenalcorticism is it again?
It's also said because you don't see an electrolyte imbalance, is that right?
Don't see electrolyte imbalance, because we also know what this animal's history is, and that you're given the steroids is not going to cause a primary hypoadrenalcorticism, it's going to cause it as mediated through the pituitary. Giving steroids to an animal is not going to cause the adrenal just to automatically atrophy. It's because the ACTH, which normally stimulates those cells, is not being released. Everybody follow that? And that's why we get to secondary. Then that explains that right there, okay? Well, if you abruptly stop giving this dog glucocorticoids, they develop severe hypoadrenalcorticism. Why? What did we just say? What has the adrenal gland not been getting for the years that this animal's been under this? You're not getting ACTH, so what layers are going to be messed up in the adrenal gland? Vesiculata and also the reticularis, but we don't have to worry much about the reticularis, do we? We do the vesiculata. And that basically is in there. Does everybody follow that, what we just said? That's the whole basis of this disease process, okay? Well, you got to gradually decrease the dosage, as we say. You may not be able to take them off of it entirely, but you want to get the lowest dose possible. And hopefully, you can take them off entirely. But for that long, you may not be able to. All right, so that is primary hypoadrenalcorticism on that one, and secondary. So that's the hypoadrenalcorticism. Guess what we're going to talk about next?
Hyper.
How'd you figure that out?
Just a guess.
Just did, huh? Kidneys, right? I don't want to update anything. Just go away. Okay? My computer, we're updating it. Seems like every time they update computers, we got more and more problems with them. Maybe it's just me, but I don't know. All right, well, terminology for hyperadrenal ADH, antidiuretic hormone, right? But remember, it also means adrenal-dependent hyperadrenal. So be sure you read the questions thoroughly and don't say, oh, ADH, that's antidiuretic hormone. I said, wait a minute, this doesn't seem to have anything to do with that. You know, don't do that, okay? What do you think PDH means? Pituitary-dependent hyperadrenal. Okay? Cushing's disease, as we say, refers to those cases in which the hypercortisolism is secondary to inappropriate ACTH secretion. So it is synonymous with PDH. Okay? Whereas Cushing's syndrome is anything which causes excessive levels of glucocorticoids. That can be iatrogenic, it can be primary, it can be secondary. Okay? Well, as far as secondary hyperadrenal, again, the pituitary-dependent hyperadrenal, Cushing's disease, is due to excessive ACTH secretion. And that's from the pituitary, okay? And what do you think would probably be the most likely thing in the pituitary that would do that? What cells secrete ACTH rather? Corticotropes. And the corticotropes are classified also being chromophobes. So corticotropic adenoma, chromophobe adenoma means it's a neoplasm. Adenoma is functional, so it's producing too much ACTH. And that's the most common form of hyperadrenal in the cat and the horse, and the second most common as far as the dog, as far as the chromophobe adenoma. Okay, dog has other problems too. Most common thing in the dog is iatrogenic. Okay? And again, it's getting that way in cats. Works in dogs, let's use it for the cat, right? And we get carried away with it sometimes, all right? All right, so they used to think that the most common form of hyperadrenal in the cat was primary. And we'll find out why. I'll ask y'all after we finish lecturing this part, we'll ask y'all why. You tell me, okay? All right, well, here is a chromophobe adenoma. You see the adenoma down there? Little dark thing down there? You think that might have some other wide range effects?
No.
What about the somatotropes and the thyrotropes and everything else? You think they're happy about being crowded? Now, you may push them back enough and they can still function. But as this progresses, then you're going to see more of a pan-hyperpituitarism going on with the other things. And all you're going to see is this excessive ACTH secretion. Okay? Pardon me. But this animal, this was from a golden retriever. It was chromophobe adenoma. Been found in a 13-year-old golden retriever. It had been successfully treated for hyperadrenal for 5 years. And there were no neurological signs associated with this tumor, but what do you think happened to the rest of the pituitary as this tumor got bigger? And so that's why this is not a live animal anymore. Okay, if y'all can tell me how you can take out the brain like that and section it in half, keep it alive, and y'all more skilled at surgery than I do. Okay. Okay, just saying, this is saying we got pituitary dependent. The adrenals right there, you got, pardon me, the normal adrenals are the smaller ones there. Okay, the other adrenals are what? They're hypertrophied. Remember, with primary hyperadrenal we're going to get adrenal atrophy. What are we going to get with primary hyperadrenal or secondary hyperadrenal either one? We're going to get big ones. Okay, that's what we're saying here. And the thing is, the histological section from one of the affected adrenals is in the other picture there. And you can see hyperplasia, see all the vacuolation and everything in the cortex and everything. Those are very active cells. The more vacuolated it is, the more active, because what do the steroid hormones come from? Cholesterol and that type of thing. And so you're going to get a lot of it in there, so it's going to be a lipoid thing, so it's not going to stain or routine staining, H&E stain like we have here. Okay. Again, here's adrenals in the middle. Across the middle are normal. What's about the ones on top? They're atrophied. What about the ones on the bottom? That's hypertrophied. Okay, now I don't recommend trying to make a diagnosis by going in there and taking out the adrenals, looking at them like this. This is on necropsy. Okay. Now, as far as the classification again, if it's adrenal-dependent hyperadrenal that's less common than secondary. It usually results from excessive cortisol excretion by an adrenal tumor. It can be unilateral, and what will happen to the other adrenal if you have a unilateral tumor? The adrenal will atrophy. But which species doesn't read the book? Cats can have bilateral tumors, and they can also have idiopathic bilateral hypertrophy. What's idiopathic mean? You don't know what happened to it. It's just it can happen in any species, but most often in the cat. Okay. Idiopathic, as I say, has been mainly reported in some dogs, but it's mainly in the cat. Okay. Now, this is just showing a large adrenal adenoma on that slide there, the gross section there. This has been cut in half. With functional adenoma, the contralateral glands usually atrophied, as we say, due to the negative feedback, because if you've got too much cortisol coming from the tumor, what's it tell the pituitary and the hypothalamus? You don't need to send anything down here. And so what is the gland that's normal saying? I'm not getting any stimulation, I'm just going to shrivel up, right? And so it atrophies. And again, that's a microscopic section. You can see how vacuolated it is. That's from the tumor there. Okay, this is an adrenal cortical carcinoma there on the right adrenal gland. It's invading the phenolic-abdominal vein. So what does that tell? Y'all see it in the vein there? Oh, if I can get up here, I've been sitting too long here. See the vessel right here? What's inside of it? Tumor. What's this tumor doing? It's metastasizing, isn't it? Okay. And this is a cut surface of both adrenal glands from this case. And which one do you think was affected? This was the right, this was the left right here. What happened to the left? Atrophied. Okay. This is a gross picture of adrenal carcinoma. They're less frequent than adenomas. About 80% of your carcinomas may be functional and cause adrenal-dependent hyperadrenocorticism. And in humans, this is much more prevalent. These carcinomas are much more prevalent. Okay? Most in animals, those carcinomas may not be functional, but they're invasive. So that's how they cause problems. And that's just a microscopic section. You can see it doesn't look like nice, normal little, endocrine cells in there, and they're just growing like crazy. All right, well, let's look at some general information on canine and feline hyperadrenocorticism, both PDH and ADH, as far as etiology, incidence, and signalement. Notice canine and feline are together, so that means it's very similar as far as what you'll see, okay? As far as etiology and canine hyperadrenocorticism, can have a lot of different causes, but the common denominator is too much production of cortisol, okay? In cases of your naturally occurring canine hyperadrenocorticism, again, about 80 to 85% are pituitary dependent, and the remainder are adrenal dependent. Okay. And the most common cause of iatrogenic hyperadrenocorticism is giving too much glucocorticoids for therapy. Usually, if the animal itches, give it steroids. If your skin's dry, give it steroids. All this type of thing. So, kind of I hate to say it, but a misuse of a drug. That's what's causing this. As far as the incidence, hyperadrenocorticism is one of the most common endocrinopathies that you'll diagnose in the dog. And why is the diagnosis important in there? Does that necessarily mean it's the most common that occurs in the species? But what determines the incidence? How often you see it, right? And so there might be something out there that the animal dies before you see it or something like that. But of the things you get in the clinic, this is one of the highest incidences. Okay? As far as the signalement, the majority of the dogs that have pituitary dependent and adrenal dependent are your older animals. The age range, really narrow age range from 4 to 14 years, but it's usually around 7 to 9 years of age. But that doesn't mean that a younger animal can't get it. It just means that this is the usual thing we see. About 55 to 60% of the dogs that we get with pituitary dependent are females, and about 60 to 65% with adrenal dependent are females. So you subtract that when you get the incidence in the males from that, okay? All right. As far as small breeds, if I ask you, or you see a question on any exams that says, what's one of the most common breeds associated with this endocrinopathy? Generally, you can get away with miniature poodles. Okay? Dachshunds, Boston Terriers, Silky Terriers, those are the most common affected, but any breed can get it. Just because they're not one of these breeds does not mean that you don't considered as a diagnosis. It appears to be higher as far as adrenal dependent in toy poodles and other poodle breeds, German shepherds, dachshunds, Labrador retrievers, and various terrier breeds. The higher proportion of dogs with ADH are larger animals. Okay, with a weight more than 20 kilograms and stuff. Now that means those German Shepherd and Labrador Retrievers aren't reading the book there, because they can get both, okay? As far as etiology, in the feline, causes of hyperrenal corticism is basically similar to those that we saw in the dog. In cases of naturally occurring feline hyperrenal corticism, about 75 to 80% is pituitary dependent and the remainder is adrenal dependent. And again, they used to think that it was adrenal dependent, because remember the test we went through, the dexamethasone suppression test, high dose dex we used to differentiate between primary and secondary? It doesn't work in the cat. So since it didn't work, so that means it's not up here in the pituitary. It's because in the cat, and also in the horse, they're located mainly in the intermediate section of the pituitary, and they don't respond to high dose dexamethasone suppression. So we were erroneously diagnosing them. Okay? And iatrogenic is less common in cats, but take out the much now. This was written 2 years ago, but we're getting carried away as far as giving steroids in cats these days. Okay? As far as hyperrenal corticism is relatively rare in cats, mainly because the iatrogenic causes have not been that high, but it will increase. As you all go through your career, it's going to increase in incidence. Signalment, a majority of your affected cats are middle-aged or older. The average is about 10 to 11 years, so they are older as far as considered dog breeds. There's no particular breed predilection, but it seems what's usually more affected by things, the purebreds or the mixed breeds? Purebreds, but this is not the same. The mixed breeding is mostly what we see, but what is the highest population of cats in this country? Mixed breeds, so that may influence what we're going to see. Okay? And as far as about the sex predilection, about approximately 70% of cats with hyperrenal corticism are females. So it's not as high incidence in males. Maybe because they're not quite as stressed. I know that little kitten is a female, and she stresses all get out. My other cat's a male, and he's laid back like crazy until the kitten attacks him. So he's probably going to develop this problem now because of this kitten, okay? So what are some of the general problems and clinical signs associated with these conditions in canine and feline? Bilateral symmetrical alopecia is one of the most common findings in dogs. It's seen secondary to hyperrenal corticism because it causes atrophy of the hair follicles. And if you have atrophy of the hair follicles, what happens to the hair? It falls out. Do you replace it? No. Okay? And it's usually going to involve the lateral thighs, abdomen, and back. Spares the head and the extremities. Now as it progresses, it may get those also. And again, when you remove the hair covering from the skin, what do you expose the skin to? UV radiation. What does that do to melanoblast and stuff? Activates them, and so you get darkening, hyperpigmentation, and what's that called? Acanthosis nigrans, or hyperpigmentation. If you're asked to put that down and answer, you don't remember how to spell acanthosis nigrans, you might have to result to hyperpigmentation, right? But that's the question asked you, what is this hyperpigmentation called? Hyperpigmentation. Yeah. And as far as the alopecia, it's not as common in cats as it is in dogs. Cats get more of a patchy-like things. You know, what do cats do all the time? They groom themselves. They stop doing this. And so you get unkempt hair coat. So you'll lose some areas, but it won't be this symmetrical thing. It'll be clumps and clusters of hair. It's usually patchy. Okay, here is showing a dog that has a loss of hair on the back of the dog. It's an unknown breed because they didn't know what they were picturing here. This has pituitary-dependent hyperrenal corticism. Now this is the beginning stages, so it's not as bad. So it's just going to progress from there. Here you can see the hair coat, the loss of hair on the back and sides of this little bearded collie here. And also the pot belly. They're supposed to be very trim dogs. You can see the abdomen sagging. And the abdomen sags, one, because the liver gets big. The urinary bladder, since you can't express the urine very much, it gets enlarged. You thin connective tissue, and you're also breaking down muscle for glucose. You put all those together, what's going to happen to the abdominal tone? You lose it. Okay? Now what about this? This is not a grooming thing here. But you can see it's maintained hair on the paws and the head, right? For now. And this one right here, poodle has got it. Now what about this little old dog? It's lost almost all its hair, hasn't it? And plus look at the body contour and everything. This is not good, is it? And this is just showing you why you're getting the follicular atrophy. The section on your all's left is a normal skin section. What's missing on the right there? What about the thickness of the epidermis? It's thinner. What about the connective tissue? You've lost all that pink over there in the normal section you've lost, so it's very thin. What about the hair follicles? Are they nice and big and round, or are they shrunken and small?
Everything is small.
And that's what you get. Notice you can also get a lot of fat, redistribution of fat, and that's what all that fat is down there, the subcutis. Okay, here's alopecia and hyperpigmentation from hyperdenoccorticism. Now, hypothyroidism can also cause this. So again, you have to use your diagnostic test to make sure what you got. This little guy here, doesn't look like he's upset about it, does it? Okay. Isn't that just a larger dog right here? You can see all the hyperpigmentation on the abdomen here. Hope y'all don't mind the pictures, but I think the best way to remember something is look at the pictures. Now what about this nice, neat looking cat here? This is what we call unkempt appearance. Okay, it's just patchy alopecia. And you can get some larger areas as it progresses. This is what a lot of them look like. What about the body condition of this cat? Nice and healthy, or does it don't look very good? I know that's not a clinical syndrome, don't look very good, but again, here's the feline. You can see we actually have more of the hair falling out on this one, but it's patchy. It's not that bilateral, symmetrical stuff that we saw.